Bismillah ar-Rahman ar-Rahim. Mr. Chairman, Professor Rafat, thank you for your introduction. I'd like to thank Professor Ines Shaltut for this and the ASD for this highly successful conference. وأشكر حضراتكم. I am the last talk. It's my pleasure to be the last talk. وأشكر حضراتكم على الحضور المميز طول اليوم وبالذات till the last talk. So because I am the last, I will try to be so concise to highlight some important points on obesity. What about obesity and the kidney? And this is the prevalence of obesity in general worldwide by 2014. And you can see that this is our place in Egypt. And as Professor Muhammad Hassanin said from 100 million Saha, that we have a high prevalence of obesity, and this is in comparison to other countries. If you look to this WHO record, you can see that we are in the red zones, approaching more than 35, mainly over 35% body mass index, and we are in the red zones regarding our countries. This is in CKD. I will go on in CKD directly. These are class 1, class 2. This class 1 in the yellow, blue, will be light blue, and up to class 3 over the years from 1999 to 2014. These statistics show that people with CKD show higher prevalence of obesity, and you can see that increasing class 3 obesity over years, but all other classes are decreasing in spite of increase the main number of obesity. So the net result of obesity increases, the net amount, and mainly from class 3 as years passes. So we are going more obese patients and more obese. The problem with CKD that body mass index is a poor metric body fat distribution, unable to differentiate between fat and muscle mass. We measure the patient weight and all. And our patients with CKD are known by having low muscle mass, especially if malnutrition supervenes in the later stage of CKD. So the distribution is different. Is this body mass index represents fat or represents muscles? And also by accurate comparison, nearly 30% difference was found by plethysmography in this study using fat distribution. We found that body mass index is mainly related to fat distribution, not muscle mass. This is body mass distribution, as you can see, in CKD patients and in no CKD patients. As we approach severe obesity, more patients with CKD are found to be obese, and then patients with no CKD in comparison to normal body mass and overweight. So, after adjusting for the presence of hypertension, diabetes, history of smoking, and cardiovascular disease, risk of end-stage renal disease, there is a stepwise increased fashion in body mass index rose. So, CKD is prevalent in, obesity is prevalent in diabetic patients. So what about the reverse? What about GFR in obese patients? This study in BMJ by 2019 shows that as body mass index increases, there is rate of decline of GFR increases. So both are present. We have high prevalence of obesity in CKD patients and increased GFR decline in obese patient with CKD. Here comes an important question. Why is this decline of GFR in patients with obesity? You can see that this is obesity and know all the causes of physical inactivity, eating behavior, socioeconomic state, environmental causes, and genetics. These are translated into obesity with known complications including insulin resistance, cardiovascular disease, arthritis, cancer, obstructive sleep apnea, psychological problems, and infertility. You can add CKD as one of the complications now of obesity. CKD now is considered one of the complications of the obesity. Many talks by many elegant professors highlighted this. What are the adipokines and what are the cytokines secreted by adipocytes? Adipocytes are not silent cells. They secrete many cytokines. These cytokines act on cardiovascular disease, act on hypertension, angiogenesis, and on reproduction and lipid metabolism. Of these important are leptin increasing activation of sympathetic nervous system, and activation of endothelial dysfunction by resistance secreted by adipocytes, interleukin 6 causing again endothelial dysfunction, and tumor necrosis alpha causing increased insulin resistance and endothelial dysfunction. So, the obese patient, due to many metabolic disorders, the presence of hypertension, RAS activation, and sympathetic nervous system activation, systemic inflammation due to many cytokines, the presence of insulin resistance, adipokines release, increased gut toxin permeability, and lipotoxicity, endothelial dysfunction, all of this results in some sort of kidney failure. What is this? Glomerular hyperfiltration, glomerulomegaly, podocyte dysfunction, interstitial fibrosis, and tubular interstitial damage. These are the main manifestations of kidney disease, and we can simply classify them on a histological basis into glomerular and tubular division. We have glomerular changes and tubular changes. The main issue is glomerular hyperfiltration. This is the main factor to cause glomerular injury in kidney disease. Activation of RAS system, you know all this story. Angiotensinogen, angiotensin 2, angiotensin 1, angiotensin 2, activating 81 and 82 receptors. Increase salt aldosterone and salt and water retention. This story ends by nitric oxide. And this nitric oxide and have some in some limbs. And this nitric oxide results in vasodilatation of the glomerular endothelium. And this results in glomerular hyperfiltration. This is the normal glomerulus. This cartoon shows the normal glomerulus. As you can see, the podocytes in between are spaces are normal and no proteinuria. As glomeruli increases in size due to hyperfiltration, they react by increasing the size, and we found glomerular hypertrophy. This glomerular hypertrophy results in disruption in podocyte interspaces and what is known as proteinuria clinically. So mainly proteinuria, and this proteinuria is translated mainly in a histological lesion that is called focal segmental glomerulosclerosis, or what we abbreviate as FSGS. This is a definition by 2013 of obesity-associated glomerulopathy, a proteinuric renal disease in patients with BMI values of 30 kilogram per square meter, without any clinical and histological evidence of any other renal disease. So obesity is the only disease present to cause these associated glomerulopathy. What about tubular lesion? Proteinuria initiates many profibrotic factors, including tumor necrosis factor, TGF-beta, and this initiates, in addition to cytokines I have mentioned briefly, interstitial inflammation. Interstitial inflammation, in addition to these profibrotic factors, results in interstitial fibrosis. So the net results in the tubules is tubular atrophy, hypertrophy, proximal tubules, tubular apoptosis, increased tubular apoptosis, and oxidative cell stresses. These cofactors act on the tubules and results in increased tubular fibrosis. And we can calculate the amount in tubular fibrosis in renal biopsy, as you can see. And this guarantees how much is it CKD, or how much is this kidney is known to be chronic. One of the major factors we can go to see what's chronic is the amount of interstitial fibrosis. A pathogenic role for dysbiosis and increased gut microbiota, increased gut toxin permeability in patients with obesity was observed with increased inflammation. And this is one now of the proposed mechanisms for the CKD, and targeting gut microbiota is one of the proposed theories to delay the progression of CKD. This is the histological picture. You can see that the glomeruli, hypertrophy of the glomeruli, and this is close picture, increased size of the glomeruli, and FSGS, focal segmental sclerosis. These are the red areas, and you can see in close picture, this is the red areas, and it is perihilar. This is the hilum of the glomerulus. So it is perihilar obesity-related FSGS. This is in comparison of idiopathic FSGS we found in normal patients, that one of its lesions is tip lesion, which is present in the tip of the glomeruli. This is the very close picture showing that the hilum and perihilar sclerosis, or increased amount of the mesangium, which is known, marked by red color, as FSGS perihilar glomerulosclerosis. Other factors include increased measured parenchymal volume and the estimated cortical volume of the kidneys, and enhanced renal lipid deposition were found in kidneys of obesity. And so this is the pathogenesis and the pathological pictures, and the main picture, hyperfiltration, which is translated into FSGS or focal segmental glomerulosclerosis together with tubular atrophy. Few highlights about the treatment of this condition. Of course, diet, as we are talking about obesity. How about protein intake, salt intake, caloric intake? What about ketogenic diet? Proteinuria control, RAS inhibitors, SGLT2 inhibitors. Some drugs, and were mentioned in many talks, and role of surgery, as Professor Wasi mentioned now. Regarding nutritional treatment of obesity, please realize a dietary plan with controlled caloric restriction. It is an important point, controlled caloric restriction, not over caloric restriction. Please take care of caloric restriction. Patient needs calorie to perform their life. Encourage regular physical activity, which is very important. Daily intake of whole grains and olive oil. 5 portions of vegetables and fruits per day. A portion of legumes 2 times per week. Fish and fishery products are the main source of high biological value protein, depends on fish and fishery products, which is known as Mediterranean diet. Discourage the assumption of red meat, sugar, desserts, sugar beverages, and processed meats, high sodium food, and cheeses. Regarding protein intake, we have 4 types of protein intake according to stages of kidney CKD. Normal diet, 0.8 gram per kg per day. In general adult, stage 1 to 3. Low protein diet, lowering 8.6 gram, 0.4 of animal origin and 0.2 of plant origin in patient stage 3 to 5. Low protein vegans diet, depending only vegetable source, midway about 0.7, mainly from vegetable source, not from animal source. And supplemented very low protein diet, depending on the supplement of branched chain fatty acids in addition to protein restriction. And we are to remember that protein restriction, branched chain fatty acid supplementation is, you must be combined with good protein restriction. To use branched chain fatty acids as CKD, delaying progression, we are to be in stage 4 to 5, and accompanied by protein restriction. Salt intake, daily consumption of sodium chloride should not exceed 5-6 grams. Hyposodium diet, and please remember that decreasing sodium can lead to hypotension. Or restricting sodium can lead to hypotension, and this can lead, in addition to impairment of the glomerular blood supply. DASH diet, decreasing sodium, decreasing salt intake, reduction was known to cause reduction in blood pressure in obese patients, and Mediterranean diet, depending mainly on fishery products as their proteins, restriction of vegetable carbohydrates are recommended. And this study in internal medicine was found 2021. Mediterranean diet represents the best evidence-based nutritional approach for the reduction of cardiovascular risk and incidence of metabolic diseases. Caloric intake stage 3 to 5 recommended 35 kilocalorie, and 30 to 35 older than 60 years. Please don't use very low caloric restriction, include kidney as contraindicated in kidney failure and patient CKD. About 30 to 35 calories per day, per kilogram per day. Ketogenic diet in intermittent stages of CKD was found to slow progression and rapid weight loss, especially in association with diabetes and hyperinsulinemia. And these studies, for example, stage 2-month ketogenic diet in animals shown to completely reverse diabetic nephropathy with an improvement in glomerular histopathology. And in polycystic kidney disease progression, delaying polycystic kidney disease progression by administration of this beta-hydroxybutyrate. So activity and action, evaluation of clinical condition has been carried on to exclude potential contraindication. Adequate patient selection has previously been made. Please individualize your action. Dietary treatment is accurately tailored to the patient, again individualized. Dietary treatment is carried out under strict medical control. No one size fits all, and medical control is essential in dietitian. I am an nephrologist, and I need a dietitian with me. I cannot do this job alone. And usually nowadays, nutritionists are present hand in hand in dialysis units and in CKD managing clinics with nephrologists, even in our centers here. What about proteinuria? RAS blockers are known to cause reduction of proteinuria, and this is a difference according to body mass less than 25 to 30. This is the difference in proteinuria between patient taking ramipril and not ramipril. And of course, reduction according to in various stages, and we are as the stage increases of body mass index, the reduction of proteinuria increases. SGLT2 are now known to decrease proteinuria by known mechanisms. You know, we are fibroblast growth factor independent or FGF21 dependent ways to decrease fat mass, decrease adipocytes, and increase activation of lipolysis. So they seem to have a specific action in diabetic obesity, kidney disease, or obesity-associated glomerulopathy. What about the drugs? Liraglutide, approved as an example of GLP-1, approved, FDA approved. No caution, no dose adjustment, mild to moderate renal impairment, limited data and dialysis. Legalizing naltrexone, propion, illustrated by Professor Amr, causes urinary urgency, increased creatinine, only on moderate to severe, severe impairment, maximum 1 tablet PIT, avoid in dialysis. Orlistat, decreased concentration of cyclosporin in transplant patient, fat soluble and non-hyperoxaluria, no dose adjustment, phenetramine, cause elevation of blood pressure, up to 30, GFR 15 milligram per day. While phenetramine topiramate causes nephrolithitis, and with GFR less than 50, maximum dose is 7.5 or per day. Avoid in dialysis. Melatonin was thought to cause reduction of this effect of obesity by its anti-inflammatory, immunoregulatory molecules as a free radical scavenger, antioxidant, and circadian rhythm regulator. It could improve and even mitigate the progression of CKD in persons with obesity in this study in Internal Journal of Molecular Science by this year. Surgery, 2 types of surgery are known to have a great success, including sleeve gastrectomy or Roux-en-Y, and this is, the red is the surgery group, while the blue is the non-surgery group. This is the weight reduction in this study in Kidney International Report, and this is the GFR decline. You can see that the surgery group higher GFR than the non-surgery group. Percent of patients having doubling of serum creatinine higher in non-surgery than surgery group, while GFR decline percent of patients with GFR decline more than 30% was found to be higher in surgery than non-surgery group. In this study, in American Journal of Kidney Disease, 714 against 714 patients, surgery, not surgery. They found that this is the weight, and these are what is important for us. eGFR and GFR difference. You can see that this is no surgery and this is surgery. Higher GFR and GFR difference is, of course, higher in surgery, in non-surgery group. So surgery seems to be protective for body mass or obesity-associated glomerulopathy, and this goes with logic of improving the pathology of obesity. So in my conclusion, Mr. Chairman, obesity is prevalent among CKD patients. Obesity is related to the development and progression of CKD, vice versa. Hyperfiltration is the main issue in this glomerulopathy-associated, obesity-associated glomerulopathy. It is mainly in the form of glomerular lesion, FSGS, or tubular lesion. Diet should be used under strict control and multidisciplinary action between nephrologist and nutritionist. Mediterranean diet, supplemented very low protein diet and salt restriction, not over salt restriction than 5 grams per day. RAS blockade, SGLT2 inhibitors, GLP-1 presented by liraglutide, orlistat, and other drugs. And bariatric surgery seems to have a good effect. And thank you very much.
Thank you.